standards for blood banks. Blood banking, it's not a process, it's not process or procedure that you can handle by whatever means or by whatever instruments you have. It involves a lot of laid down rules and regulations which are being regulated starting from WHO to FDA, even CDC. So we are going to look at how they propose or how the lay down process for a standard blood banking. Okay, so standard for blood banks in terms of organization, the blood bank should be organized, equipment, how the equipment should be supplied, how you can select your equipment, organization from management to dispatch of the blood, the processes that are involved in that pathway. Then the equipment, criteria for procuring equipment in the blood bank. There are standards for all those processes. Then suppliers, process control, starting from the requests of the medical director, who will also participate in the development of the informed consent process for the recipient, okay, to the recipient, the patient himself, okay. So all the processes involve blood requests, deferment of donors, indefinitely deferment of donors or indefinitely defer recipients of HIV vaccines, donors whose partners are infected with HBV or unspecified viral hepatitis are deferred. Okay, so documents and records. All the documentations and records that are involved in any blood donation and transfusion must be retained for as long as 10 years. Okay, so after 10 years, you can dispatch or discard any documents concerning any blood transfusion, but the records must be kept for at least 10 years. Then we have also HLA standards for HLA cross-matching, where you involved tissue cross-matching, tissue transplants. Okay, so organization. In organizing the blood bank shall have a structure that clearly defines and documents the parties responsible for the provision of blood, components, and services, a defined executive management structure. The resources, both the personnel, must be evaluated for competence, and this should be done at specified intervals. Personnel record must also be maintained. Okay, equipment, all the equipment that are being employed in the process of blood banking and also donation, which involve both the donation and transfusion, shall have processes, policies, processes, and procedures to calibrate, maintain, and monitor equipment to conform to standard. There shall be defined selection criteria for equipment. The details of all these subtopics here, you can see the complete details of every step that are involved in this process. When you check the WHO standard for blood banking and also the CDC standard for blood banking, you see how each of the steps, they will tell you each of the process, they will tell you the steps to follow to achieve that. So monitoring of equipment also includes the calibration and adjustment, labeling to show calibration status, assessment of conformation of blood components, tissue, and services if equipment is found to be out of calibration. Record refrigerator or ambient temperature at least every 4 hours. So what I'm presenting to you here is sort of a summary of this process and procedure. So you have to take your time, go and download WHO standards for blood bank, and also check up the CDC standard for blood bank. So I'm trying to summarize the process, okay? So supplier and customer issues. Blood bank shall have policies to evaluate the ability of providers of critical materials and services to meet agreed upon requirements consistently. Incoming blood, components, tissues, and derivatives and critical materials shall be inspected and tested as necessary before acceptance or use. Containers and reagents must meet required criteria. And some of these criteria they are talking about, you will see it in the comprehensive documents for WHO standards for blood bank. Please download it and read it. It's very, very comprehensive. It's a very, very comprehensive document. No aspect of the process is of the step is left. So for the process control through the blood bank, in the blood bank services, the blood bank shall have policies that ensure quality of blood, components, tissues, and services. A breakdown of this policy is contained in that document. They shall have a process to develop or change existing policies. The steps involved in doing this is captured in the full documents. So it's something that you have to download. Proficiency testing for each analyte tested by the facility. The process of carrying out this proficiency testing is also documented. A program of quality control. So these are some of the processes that take place in the blood bank. Yeah. So, and there are processes through which they must be carried out. Okay, a program of quality control, sterility maintained, identification and traceability, that is being able to identify individuals performing each step in the collection, processing, testing, distribution. So each of these steps of process in identification and tracing any particular units of blood has to be thoroughly guided. All the personnel and every person involved in that pathway must be identified at each step. Who is collecting the blood, who is processing it, who is doing what, must be clearly stated. Labeling must conform to the uniform labeling of blood and blood components using the ISTB 120 protocol. So donor identification and link to existing donor records. Recipient blood collections, recipients identification positively and label attached to tube at recipient's side. Access to storage areas and authorization to remove content should be controlled. Okay. The personnel that have access to where blood are being stored and also to remove any old pints or to do any adjustments there must be controlled. Donor informed consent requires specific consent for marrow and registry, marrow registry. So if the donor is involved in marrow transfusion, so there must be consent given by the donor because of the registry that is involved in the marrow transfusion. So the blood bank should also report suspected cases of transfusion transmitted diseases. and investigate each report. Components involved in the incident shall be identified. Donor care should be private and confidential. Standards that apply to allogenic donor also apply to apheresis donors. Blood shall be collected into a sterile closed system. So this is a summary of the process that are involved. The breakdown of each of these steps that are involved in the blood banking, you can download it from the protocol for blood banks by WHO. Donors with a history of transfusion or pregnancy shall be tested for unexpected antibodies to red cell antigens. Allogenic blood tested for hepatitis B, C, HCV, HIV 1 and 2, okay, and some serological tests like syphilis. These are fundamental, like primary, like the least that can be done, screening. Then autologous blood is transfused outside of collecting facility test before shipping on. At least the first unit shipped during each 30 days period. This is with reference to autologous blood transfusion. Okay, so blood bank shall have process for quarantine and disposition of all prior collection when a repeat donor tests positive. So when a known donor suddenly tests positive for some of these viral screening that are being carried out, the blood bank shall have a process of quarantining and also removing all other units that are connected to such donor. Requests for blood or components must contain sufficient information to uniquely identify the recipient, including two independent identifiers like the barcode. Barcode can serve as an independent identifier. So the process of identifying the recipient should be very thorough. And for the step 1, 2, 3, 4 on how to achieve this, it's very, very comprehensive in that document. If you can't access it, you let me know, but I think it's freely available. Before transfusion, ABO group of all units of whole blood and components labeled resource shall be confirmed. Before transfusion, you repeat the ABO blood group of all the units and their resource status. You repeat before transfusion, even though in the blood bank they labeled this bag B positive, kept it in the blood bank there. But before transfusion, as you're about to cross match, you still repeat this process of blood grouping. Okay. For the U, weak DU, confirmation may not be required. Okay. There is a need to detect ABO and resource discrepancy between the current donation and previous donation by the same donor, compared to typing performed in the last 12 months. Sometimes we can encounter some discrepancies in cross-matching, especially when a patient has been transfused repeatedly. Such patients that receive repeated blood transfusion tend to develop some antibodies, okay, so that getting a compatible blood for them becomes difficult. So in such cases, you may want to go back to the early typing you did, at least in the 12 months, to be able to identify any new antibody that the recipient has developed. Testing clinically significant antibody shall be done at 37 degrees centigrade. If patient has been transfused or pregnant in last 3 months, blood drawn 3 days before scheduled transfusion. So the patient should be screened okay, 3 days prior to the transfusion, so that you don't encounter this new antibodies suddenly. Maybe the patient is already critical, needing the blood, and you are just identifying the antibody. So it's good to also plan the cross match early when you have a known patient that have been receiving transfusion repeatedly. So also plasma components is the regulation in blood banks that plasma components shall also be ABO compatible. The blood bank should also have policy concerning components that contain significant amounts of incompatible ABO antibodies or unexpected red cell antibodies. Okay. Granulocytes and platelets have to be ABO compatible unless components contain less than 2 mils of red cells. There is need also for blood bank to have policy regarding SMV virus and hemoglobin S donors or recipients. Okay. So please mute your stuff. Okay. So final inspection of blood and components before issue. There should be an independent final inspection of blood before they are being issued. It's not the personnel or the individuals that are involved in the processing or cross-matching or labeling that should do this inspection. An independent personnel should come and inspect every blood before it is being finally issued, checking the documents, corresponding them with the donor and the recipients and all that. Reissue only if following conditions are observed. Container closure has not been disturbed. Red blood cell not warmed above 10 degrees or cooled below 1 degree. Okay, so that the blood bank is maintained so that the temperature does not drop below 1 degree centigrade. One sealed segment, that's why the blood bank refrigerator is quite different from the normal household refrigerator we used, because they are not at the same temperature, and that of blood bank is being maintained not below 1 degree centigrade. Okay. One sealed segment remains integral and number matches remaining sealed segments. Then they can be reattached. Blood has been inspected, so it's trying to help us with the process of inspecting the blood that has been cross-matched by an independent personnel before this blood is being issued. In situation where there is an urgent request for blood and the recipient's ABO is not known and is a case of emergency, serious emergency, you can give O red cells. If the ABO type is not known, you can quickly give O red cells, not whole blood. You can quickly give O red cells. Okay, if the ABO is known, receive group specific blood. Okay, so in situations of emergency and the blood type of the recipient is not known, you can quickly issue red blood cell or red cells, not the whole blood. You separate, you give packed cells, packed or red cells in situation where the ABO blood group of the recipient is not known. But if the ABO blood group of the recipient is known and is still in emergency situation, you can just give the same type of ABO blood group and then still continue the process of cross-match. So, blood donation types. In blood donation, we have different types of blood donation. We have autologous donors, okay? We have plasmapheresis, we have cytopheresis, we have whole blood, we have platelet pheresis. So each of them serves a very unique purpose. For the autologous donor, it has to be performed within 72 hours prior to the surgery. So a process where somebody donates his own blood to use during surgery. But this has to be done 3 days before the planned surgery. But if there are any bacterial infection, you have to defer, may not be able to carry out this process because it will cause transfusion reaction, may lead to sepsis. Okay, so for plasmapheresis, this should be done no more than not more than once in 4 weeks. If that is in a month, should be done once. And the patient has to be examined and also tested. Okay. So cytopheresis is a procedure where we select the specific cell type we need. Okay, and it can be done at least 2 days and no more than 2 times a week. Okay, or 24 times in a year. So also whole blood, the interval for donating whole blood can be 8 weeks. Okay. So for platelet pheresis, it can be 4 weeks. So some of the components we can get from any blood from the whole blood include, we can have transfused blood as whole blood. Okay, that is blood containing the full components, both the plasma, the cells, nothing is separated with it. So we collected in anticoagulants. We store it at this temperature 1 to 6. Then the expiration date is up to 21 days, depending on the anticoagulant, or 35 days if it is in a CPDA. Then we can also have whole blood that is irradiated. We can have red blood cells. We can collect blood and then separate the plasma from the cells. Okay, can stay up to the same expiry date with the whole blood. Okay, also red blood cell can be also be frozen or deglycerized. Okay, when red blood cell is frozen at -65 or -120, can actually store for 10 years. Okay, we have red blood cells that are also leukocyte reduced. The number of leukocytes are removed from the red cells using special filters. We can have packed cells, packed platelets, and we also have cryoprecipitates containing the anti-hemophilic factor, or we can anti-hemophilic factor, and we can also have the fresh frozen plasma. Yeah. I think we've discussed the process of separating these components in our first lecture. So donor qualification. So the document I asked you to look into, there was first assignment. I don't know, class rep, if you can come tomorrow, I'll be around tomorrow morning so that we finalize this assignment. So the first assignment that was in the first lecture we did, plus these donor qualifications, we are going to extract this information from that WHO standard for blood bank. So for records in blood banks, keeping records in blood bank, there are process and procedures. You don't just collect blood from somebody and then transfuse to someone and then discard everything that is connected to that blood. And such situations have led to problems where someone can be transfused. Maybe it may be someone, maybe the person already have HIV and is in window period. Maybe he has HIV and is in window period and does not know that he has HIV, and he comes to a clinic to receive blood donation, and then he was screened at that time and was found negative, and also the blood bank also screened also their own blood, their donor and their blood, and also everything was compatible and their blood was also negative. And then this patient was now transfused, and now later the patient who has HIV previously now developed HIV, he can come up to your facility and claim that the damage was done from there. So that is why it is critical to keep records in blood banking, because anything can happen in future and reference will be made to the treatment that was received in a facility, and then the blood bank traced to the blood bank where the blood was um, uh, 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 brought from. Okay, so in blood banking, records are kept for some specific time before they are discarded to avoid either transfusion reactions or problems such as this. So records need to be, there is need to be able to trace a unit of blood from its source to its final disposition. There is need that the process should be introduced to the computer system, okay, software and database, risk analysis, training, validation. So there is need to even electronically capture these records and information about any recipient, any donor, any blood bank, any recipients, and the cross-matching and that was done. Okay, so for the records and retention time, the time allocated, the time prescribed that the documents involved in that process should be retained in the blood bank. Okay, for unique unit identification, the records should be kept at least 10 years. Medical director approval for exemption to donate, the records should be retained. Donor placed on indefinite deferral, the records should be kept indefinitely. Investigation of transfusion transmitted disease, the record should be kept 10 years. ABO donor resource type, the donor has to keep the record for at least 5 years. Donor testing for unexplained antibodies, keep the record for at least 10 years. HCV or HIV look back, the record should be kept at least 10 years. Recipient's ABO or resource type, the record should be kept for this long, and so other things that are involved in the problem. If there are orders for tissue, the record should be kept. Archival of obsolete documents should be kept for 5 years. Okay, suspected transfusion complication, 5 years. So all this process, their records should be kept in case of any eventuality that may come up. So transfusion related complications, there shall be process for the detection, reporting, and evaluation of suspected complication. And I say that these processes are also documented in that document, how you will achieve this documentation too. Fatal donor or transfusion reactions shall be reported. The process of reporting it is also there. Monitoring of blood utilization. There should be peer review program, process improvement, how to monitor the blood that have been donated and have been approved for a recipient and have been dispatched. How do you monitor the process? How do you review how the blood is being utilized? Okay. utilization. It will also help to prevent undue wastage on discard of blood. And then facilities and safety. Ensure the provision of safe and adequate environmental condition. Storage of blood decreases the glucose, the pH. By day 5, factor 5 deteriorates and there is increase in potassium. There is drop in 2,3-DPG, okay, affecting the oxygen dissociation curve. Irradiation decreases red blood cell shelf life to 3 weeks and damaging the sodium potassium pump. How to evaluate bag for contamination? You check hemolysis. If it is purple, you know it may be pseudomonas. If there are clots, then citrate consuming organisms or air bubbles. So, storage of blood, you should know that storing blood also decreases the viability of the blood properties. Indication for blood products. We've said it that the best practice is to give the components the patient require. You can only give whole blood when the patient is losing blood, actively bleeding, like in accidents cases where the patient is losing both volume and cell. You can give the whole blood. But for a sickle cell patient, there is no need to give the whole blood because it will result in volume overload. The specified blood component for them is packed red cell because what they need is to increase their oxygen carrying capacity. That is what they need. They just need to increase their oxygen carrying capacity. So giving them whole blood, the plasma and the cells, it's causing a lot of harm to make them to develop undue antibodies, and it will also cause TACO to them, transfusion associated circulatory overload. So the best practice is to give the specific components which the patient requires. So indications for blood components. Red blood cell can be given to chronic symptomatic anemia like the sickle cell. They are every time chronically anemic. They are not bleeding, they are not losing blood, they are not losing any volume or plasma. It's just that their red cells are being destroyed. Okay. Okay, you can also give red blood cell in patients that are actively bleeding, but the red blood cell HB is less than 7%. But if the blood loss is less than 20, volume restoration can be done. Okay, so for fresh frozen plasma, we can give it to treat bleeding or prepare for invasive procedure or surgery in patients. Okay, platelet concentration. We give platelet concentration when there is deficiency in the extrinsic pathway, when somebody is having complications of blood clots. Okay. Cryoprecipitates in patients with von Willebrand disease, hemophilia, or congenital hyperfibrinogenemia, we can give this product. These are some of the specifications which are there. So blood, these are some of the blood products you can see in this picture. We have the plasma, we have the buffy coats, have the red cells. So you allow the blood to pack and then separate the plasma off, and you have the opaque cells, centrifuged blood, the plasma extracted, and you can see the packed cells here. So getting the right component for the right patient is key. And some of the concentrations, the dose that you are administered is what you find in this column, and the content of each. The FFP contain all the coagulation factors. So for somebody that's having coagulation problem, initially is being given FFP, but the practice this time around we give recombinant factors because FFP and plasma derived blood products have also tend to transmit viral infection. To reduce viral contamination and transmission of diseases, most practice now they use recombinant products. So that is that. Okay. Thank you very much. We are going to stop here for blood donation and blood banking. Next lecture, we will go over to blood group system. We go into the real hematology. So thank you. If you have any question, you can ask now. All right. If you have questions,